All right, this is a brief presentation over sleep that comes from your Potter and Perry textbook. So we know whether our patient is inpatient, outpatient. We know the benefits of sleep for our patients. We know functions of sleep, purpose. It's restoration of physiological function, allows our heart rate and our blood pressure to drop, so it allows our heart to rest, renews our cells, and then by decreasing the metabolic rate, it's also helping us conserve energy. Dreams, it's also essential for cognitive function and memory. So it's obviously makes sense that loss of sleep can lead to illness and disease, especially chronic disease. And just a point to remember, even if your patients are in bed, that doesn't necessarily mean it's guaranteeing rest, that they're getting that adequate sleep, that length of time, or the quality of sleep, moving through those 4 stages of non-REM or REM. So some of the physical illnesses that we see along with sleep impairment, or we might see as a cause of the sleep impairments. So hypertension and cardiovascular disease, there's a close link with insomnia, sleep disorders, obviously a lot of respiratory disorders, COPD, acute issues where there's problems with hypoxia or low oxygen concentrations, nocturia, which simply means urinating except, at night. So it could be associated with medical conditions or with medications these patients are taking, or it just could be advancing age. And then restless leg syndrome. So a lot of your patients, if there's a relation between heart disease and sleep disorders, we usually think of heart disease, hypertension, heart failure, along with patients who have problems with sleep apnea. Okay? So if patients are having problems with sleep apnea at night, that term apnea means without breathing, your oxygen concentration can actually drop, which can negatively affect your heart. Your heart needs oxygen to work effectively. So some patients at night, when they have problems with sleep apnea, and we'll talk about that in more depth in the next couple slides, if they've got pre-existing atherosclerosis disease, coronary artery disease, where they actually have blockages, if the patient has a drop in oxygen concentration through the night, it can actually induce chest pain. Anytime your heart is without oxygen, it's hypoxic, your patients can have kind of a reflex tachycardia. Their heart rate can go up. We might see ECG changes or EKG changes in addition to the tachycardia. It can put a lot of stress on the right side of our heart. Obviously, high blood pressure, absolutely. Your heart needs to work harder when it's getting decreased amounts of oxygen through the night. So, a couple of things that we can do with that link with hypertension, heart disease, and sleep disorders like sleep apnea is obviously lose weight and control blood pressure, whether it's through lifestyle alterations, diet, exercise, or it's going actually on medications. So some of the respiratory disorders that we can think of that are linked to sleep impairment, insomnia, is COPD, emphysema, which that's a component of COPD in some patients, asthma. So the long-term pulmonary diseases, obviously these patients are going to have a hard time sleeping, not only because of the problems with laying down, because they're more short of breath. Some of the medications they're on, like their inhalers, their steroids, if they're on longer-term prednisone, some of those medication side effects is restlessness, agitation, insomnia, difficulty sleeping. So in addition to the problems breathing, it's also the adverse effects of the medications to help their condition. And then obviously your patients who've got short-term respiratory problems, the congestion, the throat irritation, the cough, those things are going to interfere with a good quality sleep. Oxygen therapy is probably an important component for patients who have chronic obstructive pulmonary disease. They've found obviously there's effectiveness with sleep if patients' oxygen concentrations are where they need to be. A lot of times patients who are hypoxic and the oxygen concentration drops, These patients can wake up gasping through the night. We talked about the induction of chest pain with that. Your heart muscle needs oxygen to function. And we already talked kind of about those medications, the albuterol, the xanthine bronchodilators, the theophylline, the prednisone, steroids. And so obviously, in addition to the oxygen therapy that we're going to utilize in some of our patients with long-term pulmonary disease, supportive and symptomatic therapy, right? So antihistamines, so Benadryl, decongestants like Sudafed. But what we have to worry about decongestants is sometimes they can actually lead to insomnia, irritation, agitation, causing patients to not be able to sleep well. And then things like menthol and more of your aromatherapies that can help with the nasal congestion. So when we're thinking about nocturia, that just means like urinating at night, right? So we know that getting up through the night is going to disrupt that sleep cycle. So these patients, it's going to interrupt their various stages. So if they're in a REM sleep, we know that needs to be somewhere between 90 minutes. If they're waking up through it, they're not getting the quality that they need. So it could be linked to medical problems like heart failure. Those patients tend to urinate a little bit more frequently and even more so attributed to the medications they're on, diuretics, some of your antihypertensives that work not only to control your blood pressure, but how they do it in addition to dilating your arteries. It might be they have a diuretic component to the medication, so it's going to increase urination. So with those medications, obviously, we're going to make sure they try and take them as early in the day as possible, maybe eliminate the time frame that they take it. No longer after 5 or 6 p.m. We're not going to be taking it at 9 or 10 p.m. in the evening. Obviously, if your patients are having problems, if they don't have disease processes or medications, maybe minimize fluid and caffeine later in the day. So say I'm going to stop drinking fluids after 7 p.m. in the evening. Limit caffeine because not only is it an irritant, like a symptomatic, it's considered kind of a diuretic in some sort, so it increases urination. Making sure these patients are urinating, voiding at night before they go to bed. And then restless leg syndrome, which is different than neuropathy in your patients who have vascular disease or diabetes, okay? So usually it's going to occur before sleep, so it doesn't necessarily wake them up. So it's just going to prevent them from actually going to sleep. So really essentially what it is recurrent rhythmical movements of the legs and feet. So some of these patients might feel that they've got an itching sensation. They might feel like bugs are crawling on their legs. And so they feel like they constantly need to get up and move around or shake their legs out, promote comfort. So some of the etiology for restless leg syndrome, I think in the book it talks about Parkinson's. We might see it with nutritional deficiencies, especially anemia, vitamin B12 deficiencies, and obviously hypoxia. So if your blood flow is adequate, but yet it's not concentrated with oxygen, we're going to sense that in our extremities as well. So some of these patients, obviously, we're going to treat the underlying cause. If it's nutritional deficiencies, anemia, we're going to treat them with dietary management, supplements if we need to, hypoxia if these patients have chronic lung conditions, or even if it's a temporary condition where they need temporary oxygen at home. That's what we're going to do. Maybe hot baths, more alternative therapies like massage, acupuncture, even exercise earlier through the day. And then you can use medications. All right, so some of the other sleep disorders. So obviously the chapter really focuses on insomnia. We know that's more than just difficulty in falling asleep, it's also difficulty in staying asleep. So it's not even about the length of time we're sleeping, it's about the quality of the sleep. Okay, so it might be related to chronic or acute medical problems, kind of like we talked about a little bit. It might be related to poor sleep hygiene. As people get older, they might not be with a good bedtime routine. It may be linked to some psychological, emotional problems that's going on with the patient. And so we talked a little bit about sleep apnea, but we know these patients It's also known as obstructive sleep apnea. So these patients have periods through the night where they actually stop breathing, and it's going to be associated with snoring, okay? And it also has to do with, their airway, where it becomes a little bit softer and it kind of pushes over the main airway, and so it obstructs the airway. So a lot of times it can be with your patients who are very overweight. They have a lot of central obesity, so the abdomen is very large, and when these patients lay on their back, it pushes up and presses over their airway. Some of your patients, in combination with that, they might have really large necks, and so when they lay down on their back, everything kind of pushes over. And so you get that snoring sound because the airway is somewhat obstructed. And then in some cases, you may have sleep apnea where they go multiple seconds without breathing. And then narcolepsy. So patients can also have cataplexy and sleep paralysis. So most of these patients have periods throughout the day where they're constantly wanting to sleep, constantly feeling tired. When they go to sleep, they can go to sleep, fairly quickly, and they usually get to their REM cycle, that last stage, the stages through sleep, within 15 minutes, which most patients, it takes quite a while to get there. So they usually go into a very deep sleep quickly. We know that there's a genetic link to narcolepsy. Some of these patients can also have cataplexy, which is where in any type of intense emotional or physical stressor, these patients can have intense muscle weakness and actually, fall to the ground. So obviously with your patients who have narcolepsy, we worry about their oversleepiness, the sudden muscle weakness. So safety is a big issue with these patients. Driving, operating, operating any kind of machinery, being at home, working. So these are some things to consider. And sleep deprivation is going to be a big issue. It's not always the same thing as insomnia. So patients, obviously if patients have insomnia, they could be sleep deprived, but sometimes a lot of your patients that you take care of inpatient are going to be sleep deprived because of the care that we give them. The constantly going in to check on them, the tests, the admissions through the night, the vital signs, the physical exams, just even checking on them. So some of the medical care that we do for their benefit can actually be, harmful to them from a sleep deprivation, because research really has found that sleep deprivation can affect memory. It can affect their physiological outcomes, the quality outcomes. It can affect healing, and it can also affect vital signs, heart rate, blood pressure. So there's been research that supports the detriment of sleep deprivation in hospitalized patients. And then parasomnias usually occur in children, but if they start to occur in adults, we might look for an underlying pathologic or mental psychological component. So sleepwalking, night terrors, bedwetting at night, bruxism, which is, I think, grinding their teeth. So a lot of those things can happen in children, and they tend to outgrow them. But if this was an adult, it's new onset, or even if it was new onset in a child, I think we need to look into what factors have changed in their life, physical, I think sociocultural, any kind of change that has happened, medication adjustments, new surgery, change in the family dynamics. So if we looked at normal sleep patterns, I'm not going to read the slides to you, but I think it's important to know that obviously the younger, the more sleep they're going to be requiring versus when we get to be adults, older age, the sleep requirements decline. And so that we know that stress and illness, surgical recovery, all is going to increase our metabolic rate, which is going to increase our sleep need. So even though young adults is somewhere between 6 to 8.5 hours, you may need more during certain times of the life. So factors that influence sleep, I think drugs, substances, we talked about diuretics. I think if we talk about narcotics and antidepressants, a lot of the adverse effects that you look is sleepiness, lethargy. But I think some things to consider is though these patients may actually go to sleep, it doesn't necessarily mean that they may stay asleep for long extended periods of time, or that they're going to move through the stages that they should be. So they still may not feel well rested or rejuvenated when they wake up. So that's just kind of a point of contention. A lot of people use those things and alcohol to help them sleep when it's not necessarily the right thing to be doing. Obviously, beta blockers, that's one of the biggest side effects in addition to bradycardia, hypotension. Your patients are going to feel extremely tired, very fatigued. That's why we might encourage them to take them at night, because beta blockers, that's essentially what they do. They slow down the contractility from your heart, how your heart muscle is working. So if it's slowing down how it works, your heart rate drops. We're not getting as much out to meet the demands of the body. So we've got to start to function at a slower output. So these patients start to feel very dragged down, fatigued. Hypnotics, so like Ambien, Restoril, Xanax, Ativan, those are hypnotics. And again, used in small quantities, they can be used for sleep. But sometimes the problem with using them for sleep is that you're always going to need more. You're always going to need higher doses to help patients who use them in the long run. And so sometimes, again, just like narcotics, antidepressants, alcohol, the side effects are sleepiness, lethargy, but it doesn't mean that the sleep is quality or the length of time is appropriate. And then obviously caffeine, keeping these patients awake. So when we're thinking about lifestyle, has there been a change in work schedule, a routine, school, anything that could be increasing stress in the person's life that's keeping them up? They've got a lot of things on their mind. Environment. So has there been a change in the noise? Are you used to sleeping with a fan or that kind of that white noise to keep you? And has something changed with the routine? Exercise and fatigue. Obviously, exercise throughout the day is effective to keep the patients sleeping well at night. So sometimes if the patients started a new exercise regime and they're doing it later in the evening, that may be a reason why these patients are having insomnia, having a hard time going to sleep at night, because you've got increased sympathetic activity, right? So it's hard to bring it down to rest. And then food and caloric intake, we talked about caffeine. Nicotine sometimes is also a little bit of a stimulant in addition to a vasoconstrictor. So sometimes that might be a factor. And anytime we're looking at our patients who are having problems sleeping, this is always a component to the Potter and Perry, the nursing process. We're using our critical thinking. So obviously when we're planning how we're going to care for these patients, we're looking at, have we taken care of any other patients who've had sleep problems? What are our personal experience with sleep problems? And then we're going to look at the professional standards. What does the current research and best practice say about treating patients with insomnia? What are our scope of practice when we're in the hospital? So obviously the first thing that we're going to do is a good sleep assessment, right? And it's subjective, right? Even though we see objective signs of insomnia, it's subjective, what the patient tells us, how they feel. And so sources, obviously the patient and the family. And we're always using tools to validate and to actually measure, subjective information. It allows us to put a measurement to it. It allows us to detail what we're going to do for these patients depending on what they score on these tools. And it also provides us with a baseline, right, for us to look at and say, okay, where are these patients? Where do we want them to be? And where do we not want them to be? And so one of the biggest sleep assessment tools is the Pittsburgh Sleep Quality Index. And if you look up under the handout section, there is a PDF document for you to look at. It's super short. So obviously we're going to do a detailed sleep history, a full description of their sleeping problems. Like we said, is it a difficulty with falling asleep? Is it taking you longer than 20 to 30 minutes to fall asleep? Are you waking up frequently through the night? How are you waking up? We talked about current life events, any types of holistic issues, right? We look at the entire patient. So is it anything, emotional, psychological, physical? What are their normal bedtime routines? Do they need a bedtime routine? Are they trying to sleep too much and it's their specific age range and they shouldn't be? Sometimes patients who sleep longer than their requirements actually feel more tired. What's their environment? Where are they sleeping? What's the lighting? What's the temperature? What's the noise? And then behaviors of sleep deprivation. Are they irritable through the day? Are they having memory loss? Are they having poor performance at work? And one of the most important patient or population that we can think about this is nurses who work night shift, right? So they're coming in to take care of patients at night and they're sleep deprived. They're getting in their cars in the morning and they're driving home. So there's two phases now where we're putting other people at risk. All right, so if we looked at a more detailed description of the sleeping problems, right, we talked about that. We typically want to use open-ended questions, right? We want our patients to describe it in depth, narratively, in their own words, okay? And then we might get it a little bit more specific with some direct questions. All right, so obviously there's tons of nursing diagnoses and patient problems that we can think of, right? If it's sleep apnea, obviously ineffective breathing pattern, ineffective airway clearance. If they're having some issues with stress, anxiety, ineffective coping. And, because insomnia is more of a symptom, sometimes we can see it as a sign, but mostly a symptom, and fatigue as well. Those are nursing diagnoses. Those aren't medical diagnoses. So obviously we know about planning. This is where we are actually planning what we're going to do for our patients, setting our goals, setting our outcomes. And so implementation, this is an important slide. So what can we do for these patients, right? We're going to set bedtime routines. This is what we're going to do. We're going to encourage and promote routine bedtime. Same time, are you going to take a shower and a bath before you go to bed to help relax you? Do you need a snack? What are kind of appropriate snacks for you to be eaten? They say certain things with, milk might be a good alternative. Establish good periods of rest and sleep. So we know that patients who nap a lot through the day, they tend not to sleep as well at night. So, it's that fine balance between, yes, when patients are in the hospital, they've had surgery, they're sick, we want them to nap a little bit through the day, but we also want to be cognizant of keeping them awake enough so they sleep well at night. They say avoid excessive mental stimulation right before bed. So maybe a lot of computer time, a lot of video gaming for some of your kids. That has a little bit to do with insomnia. Environmental controls, right? Fan, room temperature, and then minimize lighting. Or do we need a light, right? Do we need a little bit of a night light for safety reasons in some of our patients? So if it's older patients that have an increased risk for confusion in the hospital, we still need to promote safety. So avoiding clutter, maybe a little bit of a night light. If we're giving diuretics or any medication that could cause an increase in urination, do it in the morning, limiting the time frame of the day. And then obviously stress reduction, making sure if we're going to exercise, do it in the day, not right before bed. Meditation, right? Guided imagery, those are all wonderful things to do before patients go to bed. And so this is a point to remember in your patients. Medication is not necessarily the first line of anything that we're going to do for patients who are having problems sleeping, but sometimes we need to. If we do, we're going to start slow and we're going to work our way up. And so usually, things like a little bit of Xanax, a little bit of Ativan might be good, but like we said, sometimes when you use benzos, you have to go to high escalating doses, and they can be very addictive. So we might try some things like melatonin. You might try a little bit of Tylenol PM, and I think there's some other more natural herbals that are out there. But again, like when we've talked about orals and naturals, we just need to make sure that we're letting the physician know what these patients are taking. And obviously minimize caffeine. So obviously some things that we can do too is positioning, making sure the linens are clean, that they're comfortable, so the patients are in good positions, especially if those are the same positions they're sleeping in at night. So some of our patients who have sleep apnea, they can actually use a CPAP, right? So you can use it nasal or by mouth. And it helps to apply a continuous amount of positive airway pressure. So it's constantly pushing pressure back in the airway to kind of maintain that airway, that upper airway open. So it can help them, obviously it's going to minimize their snoring. It's going to help to keep that airway open so it stops their breathing. to avoid stopping their breathing. But in some cases, we can actually bleed oxygen or put oxygen right through the system to help improve their oxygenation if that's what needed as well. And so a lot of your patients, if they would need to use like a full face mask, some of them are pretty resistant, right? It feels like they're suffocating initially, but some of the nasal masks are probably a little bit more comfortable and tolerable for the patients. But I think once they start to get a good night rest and they're not waking up gasping and they're not excessively cranky or tired through the day, I think you're going to see they're going to be much more receptive to it. And then when we're looking at evaluation, it's okay. So if we've made a care plan for these patients, what are we going to do for them? What are our outcomes? So some of the evaluations to outcomes might be, are you able to fall asleep within 20 minutes of getting into bed? Like that's a good standard. Describe how well you sleep when you exercise through the day. Does it help? Does quiet music at night, a fan, relaxation techniques before you go to help you relax? And then most importantly, like how are you functioning through the day? Do you feel rested when you wake up?